Good morning, everyone, and welcome to this webinar sponsored by the California Endowment and the Latino Policy and Politics Institute. We are now at a historic moment in California. Starting in January 2024, all eligible undocumented immigrants in the state would be able to enroll in full-scope Medi-Cal. In today's webinar, we will discuss with academic and community experts how we can ensure access to healthcare for undocumented immigrants in the state. For those of you who don't know LPPI, since 2017, the UCLA Latino Policy and Politics Institute has been dedicated to addressing the most critical domestic policy challenges facing Latinos and other communities of color through research, advocacy, mobilization, and leadership development. We are supported by an extensive network of nearly 50 faculty experts and an active fellowships program. And in today's webinar, it is my pleasure to introduce the speakers. Berenice Nuñez Constant, who is Senior Vice President of Government Relations at AltaMed Health Services, Tara Dar, Policy Director at California Immigrant Policy Center, Anthony Wright, the Executive Director of Health Access California, Lucia Félix Beltrán, UCLA LPPI Senior Policy Fellow, and me. So the way this webinar is going to work, we're going to have 5 minutes presentation, introductions and presentations by the speakers. And after that, we're going to be having a conversation based on the information that is presented. And for all of you to get to know what is LPPI's policy output, first, Dr. Lucia Félix Beltrán will show the main findings of a brief that LPPI produced about this topic. So please, Lucia.
Thank you for the introduction, Arturo, and good afternoon, everyone. Thank you for joining us. My name is Lucia Félix Beltrán, and I am a Senior Policy Fellow at the UCLA Latino Policy and Politics Institute. And today I will be presenting the results from a policy report that LPPI released last year related to the lessons that can be drawn from the older adult Medi-Cal expansion that can be used for the upcoming expansion in 2024. Next slide, please. This report was published in July 2023, and it is downloadable from the LPPI website, available to everyone. As I mentioned, we draw short-term implementation lessons from prior expansions to inform the upcoming expansion to all adults 26 through 49 in 2024. Next slide, please. To provide some brief context, since 2010, California has managed to reduce the share of uninsured population, mainly by expanding Medi-Cal to previously ineligible individuals. It began by expanding to children in 2015, later younger adults in 2020, and lastly in May 2022, this was open for adults who are older than 50 years of age. However, undocumented adults continue to make approximately 40% of uninsured Californians, while undocumented Latinos are the largest group of individuals who are not eligible to receive health coverage through the prescriptions of the Affordable Care Act, such as Medi-Cal and subsidies in the state exchange cover California. Approximately 368,000 older adults were eligible to Medi-Cal in August 2023. Next slide, please. This brief seeks to inform community organizations about the Medi-Cal expansion to adults 50 and above, as well as the upcoming expansion in January 2024. To do so, our research team conducted key informant interviews with multiple stakeholders with the final aim of identifying lessons of the ongoing Medi-Cal expansion in order to inform the last expansion next year. With this action, all eligible adults will now be able to enroll in full-scope Medi-Cal, regardless of immigration status. Next slide, please. Our findings can be divided into implementation lessons as well as a remaining challenge. The implementation lessons that we identified identified were access to technology, language barriers, and confusion around public charge. Regarding access to technology, we know that undocumented immigrants disproportionately lack access to computers, mobile devices, or the internet, while all of these are needed to use government services. To make up for this, our respondents, such as enrollment assistants, told us that they often support their clients by generating their email accounts and helping them submit their application forms. Related to language barriers, we know that close to half of the US immigrant population has reported limited English proficiency, contributing to bureaucratic hurdles that makes it difficult for them. And additionally, despite the fact that the Medi-Cal application is available in over 15 languages, these languages exclude indigenous languages that are spoken by individuals in their countries of origin, such as Triqui and Tzotzil, for example. Our respondents also highlighted the need for more translation services for eligible immigrants who speak indigenous languages and for those who are not covered. Finally, they also brought up that a common barrier to enrollment and use of Medi-Cal is that immigrants often have fear of public charge, of being deemed public charge, or even deportation. Despite the public charge rule was reverted to its original definition, there is still confusion around it, known as chilling effects, which continues to contribute to disenrollment or just to not enroll in public benefits. Our informants also reported that immigration status often discourages immigrants who become eligible to Medi-Cal, despite of being eligible. Finally, next slide, please. We identify that a remaining challenge stems from income eligibility thresholds of the program. Close to 1 in 3 undocumented adults who are 50 and older, or 65,000, remain eligible to the expansion because their incomes exceed 138% above the federal poverty level, which is the income's eligibility threshold, the program's eligibility threshold. These adults basically have 2 options for coverage, either to pay full price in private health insurance market or to deplete the assets to become Medi-Cal eligible, which goes totally against principles of social equity. Next slide, please. Finally, based on our findings, we proposed 3 policy recommendations. First, to continue establishing partnerships with trusted community-based organizations to address the technology, language, and immigration enrollment issues. Second, to allow undocumented immigrants with incomes above the federal poverty, the 138% of the federal poverty line, to purchase subsidized coverage in covered California. It's important to note that 2 states already did this, Colorado and Washington, and that a bill is currently being discussed in the state legislature to pursue the same. And we suggest to start with the 65,000 undocumented adults who are 50 or older who are not eligible to the Medi-Cal expansion because of their incomes. Next slide. Thank you for your attention. That is my information in case you need anything else.
Thank you, Lucia. So our next speaker is Sarah Dar, who is Policy Director of CIPC.
Hi, good morning, everybody. I'm really glad to be with all of you here today. I work at CIPC, the California Immigrant Policy Center, and along with Health Access, we've for almost a decade now worked on securing these policy changes that start to eliminate some of the barriers and exclusions to our healthcare system for this population. And so we've worked alongside so many groups across the state to help achieve these legislative victories. And many of those groups that belong to our coalition are their staff and community members and base are, folks who are impacted by this policy. And so we've learned a lot over the years about what the needs are, and also what it takes to successfully implement these policies. And we've learned a lot through the kids, young adults, and older adult expansion. And CIPC actually has made a deliberate effort to try to understand better how to be prepared for this next expansion for the adults who are 26 to 49 years old. As was mentioned, it'll be it's estimated to be the largest expansion in terms of number of people eligible compared to the kids, young adults, and older adults. And so, building on what we've learned and what's worked, and what the challenges have been from the previous expansions, CIPC conducted a series of one-on-one interviews with a number of grassroots organizations who serve low-income undocumented communities, and also a couple listening sessions. And so we've gleaned a lot. And the questions we asked were really just around, these communities best because you interact with them, in some cases on a daily basis. And we'd like to learn from you, what works well in terms of outreach and education for Medi-Cal, but also more broadly. There's lessons to be learned from, around COVID. So many of these groups were trying to help get their communities education about COVID vaccines and testing and treatment, and around other different types of know your rights information. We talked to organizations who work with workers, for example, worker centers, who work with day laborers and domestic workers. And they've done a lot of outreach among those communities to let them know about sort of their rights around health and safety protections on the job. And then there's so many other different during COVID, there was a need for all kinds of different social supports that people were really trying to step in and help connect people to, whether it's just, where to get food assistance, or there was a lot of the state allocated some dollars, and also philanthropy and different mutual aid funds were trying to gather dollars to distribute to just help folks stay afloat, if they were losing their jobs or out of work. And so a lot of these community organizations who we spoke with have experience doing that type of outreach as well, right? So whether or not it's specifically around Medi-Cal or not, there are a lot of groups out there who I think we have so much to learn from in terms of what are the best practices for helping people understand that something, is available to them, and overcoming the various different barriers that these communities face. And so what we learned from these groups is probably not a surprise to all of you, but these are communities who will face so many additional barriers to enrolling in Medi-Cal that, someone else who, has immigration status and is eligible for Medi-Cal may not face. So one is just, the first is, simply having gone so long without accessing or being eligible for public programs, not interfacing with the healthcare system in many cases, not interfacing with government programs or the county or the local human services office. Just these are systems and institutions that many of these community members have never even dealt with. And so there's a lot of just lack of awareness, for one. And confusion and mistrust, right? And obviously, especially under the previous presidential administration, there was a message being sent to these communities that, you're not deserving of public benefits and you shouldn't access services. And obviously public charge plays into that, but it goes even beyond public charge, just concerns around immigration enforcement and what people are eligible for and not. And so for this, program for Medi-Cal to now all of a sudden be available to people, it's going to take, really trusted messengers to reach these folks and let them know that there's been this big policy change and you now qualify for something that, unfortunately for many, many years, you were told you don't have options, but now you do. And that fundamental shift is, not to be underestimated, how much of a shift that is in people's understanding. And then there's all the other pieces. Language access is an issue for so many communities. We talk to folks who represent, immigrant communities that are not as populous. And so their languages are not, maybe they don't meet the Medi-Cal threshold language barrier. So materials and information from the state are not translated into their languages.
You have 1 minute left.
Oh, okay. I'll try to move quickly. So inadequate language access, and then simple things like lack of time off work in rural areas, lack of transportation and trying to travel long distances to get assistance. And then navigating the Medi-Cal application itself was a barrier we heard a lot about. It might be easy for someone who gets a regular pay stub to just report their household income every month. But for someone who gets paid in cash, or their wages or their hours fluctuate week to week, it might be confusing to even know what is my monthly income. It's not consistent. So there are a lot of those types of barriers that we encountered. But the good news is there are organizations and entities out there who, we call these in some regards, these communities are called hard to reach, but I think that's really speaking to mainstream institutions and systems who find it hard to reach these communities. There are plenty of other institutions, grassroots community-based institutions, who don't find these communities hard to reach. In fact, they're reaching them every day. And so one of the things that we've been talking a lot about is how to support and resource those organizations to be able to help make those connections and connect people to information and assistance so they can get enrolled in Medi-Cal. So huge opportunity before us, and also plenty of barriers. And CIPC and so many of our partners across the state are looking forward to working on this issue and ensuring that we maximize how many people enroll in the upcoming expansion. Thank you so much. Happy to take more questions at the end.
Thank you, Sarah. Our next speaker is Anthony Wright, who is the Executive Director of Health Access.
Hi there. Great to be with you. Great to. My name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition, working for the goal of quality, affordable healthcare for all. And I'm glad to follow Sarah from California Immigrant Policy Center, our co-chairs of the Health for All campaign, because together we represent the coming together of both the immigrant rights movement with the health reform movement to say this is the issue of removing the barrier of immigration status in order for people to get access to healthcare was a top priority for both movements moving forward. Next slide. And so we were very proud to have a campaign over the last 10 years to work methodically and in a broad coalition with over 100 organizations to try to expand coverage to a broader set of Californians. Next slide. We were proud that this coalition represented, again, the breadth of these two movements, but also involved other partners as well, folks from the broader healthcare sector. We were able to get help from again groups that are not necessarily in these spaces to recognize that it is both really important that we work in the work of CIPC to make sure that immigrants are included in every part of our society, and from the health reform point of view, when we did the Affordable Care Act, one of the big things in the Affordable Care Act was to expand Medi-Cal to everybody under 138%, whether you were a child or an adult without kids at home. But the big asterisk was immigration status, and that's what we worked to do here in California to sort of undo that exclusion that was in the federal law. Next slide. And so that's what we've done over the course of several years, working to starting in 2016 with children, and then in 2020 with young adults, and then as Lucia said, with the broader expansion in 2022 for those over 50 years old. The biggest, there's 5-6 states that cover children, but we were the first state and by far had the biggest expansion of an adult population with young adults and then seniors going forward. This expansion that will go into effect in January is by far the biggest, and together this represents coverage of over 1.3 million Californians. Many of these folks were in restricted scope or emergency Medi-Cal, so just getting having the emergency room get some reimbursement if they had an emergency, but this would give them access to primary and preventive care going forward. Next slide. very important. And that's actually one of the key messages that we used in the campaign about, just the benefit and the value of prevention. A lot of people understood that our system is more efficient and effective when people get care in primary and preventive care in the front end rather than just expensive emergency room care in the back end. The value of inclusion, again, immigrants are an important part of our society and economy and should be fully included in our health system as well. But there's also this benefit that I think Health Access and others said, that everybody benefits when everybody is included, when we can, from a public health point of view, from an economic point of view of not having a large part of our society facing financial catastrophe if they need care. And then it's the right thing to do. And those were key messages. And the most important, of course, carrier of those messages were the affected community themselves. Next slide. The obstacles that we faced, were obviously the issue of how to pay for it, how to prioritize this in a budget situation, and of course, the anti-immigrant sentiment that we see nationally. But in fact, I think that's hopefully stiffened some of California's resolve that California wanted to take a different path with regard to welcoming folks into our healthcare system. And as Sarah said, there's still lots of issues in our healthcare system with regard to outreach, with regard to administrative simplicity, with regard to affordability that we still need to tackle, and that we need to improve for everybody, including the immigrant community. And that's what we seek to do. Next slide, and my final slide, is just what are the next steps. And we absolutely agree with the recommendation that our work is not done yet, that even when we expand coverage to everybody under 138%, we need to make sure those folks are enrolled and make those systems easier, and both in terms of outreach in and then basically just even more administratively simple. But there is a threshold that at 138% of the poverty level and above, there are people there that need access. And so the question is, how can we open up covered California like we've opened up Medi-Cal? And so there will be a bill this year, AB 4 by Assemblymember Arambula, to deal with that. We are currently the Health for All campaign is currently working with Covered California to do the technical work of trying to figure out how to set up a mirror marketplace where, yes, there is an Affordable Care Act exclusion for undocumented, but we can create a mirror marketplace that will offer the same products to the same folks, and frankly use even the same portal, but to allow
1 minute left.
Allow families to really be able to use as a one-stop shop the ability to get enrolled in coverage. Our first step is to create these mechanisms to allow for enrollment, and then we will continue with the original vision of Health for All, which is to make sure that everybody in California gets access to the same help, including the same affordability assistance, regardless of your immigration status, up and down the income chain, whether you're in the Medi-Cal eligibility or in that more middle income covered California eligibility. We think it's important for all Californians, and especially for mixed status families, which is 70% of folks who are undocumented are in mixed status families. And we want to make sure the whole family can go to covered California, get enrolled, even if different people will have different levels of affordability assistance at first. So that is next slide. That's a little bit about how we got here and what our next steps are in this fight for Health for All, including and of course including the important work of getting people enrolled on the ground. And I know that's what our next speaker will talk about, but here's my contact information, and happy to take further questions. Thank you.
Thank you, Anthony. Our next speaker is Berenice, who is Senior Vice President of Government Relations at AltaMed Health Services.
Hi, everyone. Good morning. It's nice to be here with you all today. AltaMed, for those of you that don't know, is the nation's largest federally qualified health center. And today we serve 500,000 Latinos and multi-ethnic patients in LA and Orange County through 33 primary care sites, 14 dental sites, 11 PACE locations, and 3 mobile vans that we utilize in the region. It's important to note that federally qualified health centers and community clinics in California and really across the country have been caring for the undocumented for our entire history. That means that our clinics have really served as safe spaces or sanctuary clinics for these folks to come in and get the care that they deserve without any fear. And so we've done a lot of work in this space. For Latinos in particular, medical providers or physicians are among the most trusted messengers. And so we find ourselves in a very unique and privileged position to engage community and really mobilize them on the issues that are impacting them, but also to create that bridge for them to share with us their needs. And then together we can literally work with them and train them to help us engage with community and mobilize within community. And so we have been very deliberate here at AltaMed Health Services to build out not only a formal community affairs team, but an integrated civic engagement model that includes a team of folks who are doing community organizing and research, but also literal civic engagement. Like, we literally knock on our patients' doors and really meet them where they are literally, to train them and engage them on the issues that are important and that are impacting them. And so our relationship with these individuals is a really long one. And we've demonstrated over many years that they can trust us, which is really a critical component of this work, as you just heard. And so the success of our messaging and our programs has been really twofold, right? So again, we meet communities where they are in their language, and with that cultural humility that is really important. And then we leverage the community members as messengers themselves in this work. And so in response to this varying level of trust, we've actually trained 68 community residents in Southeast Los Angeles through our SELA Health Allies program, and 35 street vendors through our street vendor ambassador programs to co-plan their own community awareness campaigns for this issue. And they have been conducting monthly on the ground and digital outreach activities, leveraging their community connections. And so this includes door-to-door canvassing in their neighborhoods, outreach for from their street vendor businesses, dropping off flyers at their children's schools, organizing house meetings where our teams can provide information and provide health education through things like WhatsApp threads. And so through our My Vote My Health campaign, we literally are asking our patients to vote for their health. And so this central message has been really effective. So much so that we're now, through help from the California Endowment, are now scaling up our clinic mobilization model statewide in partnership with the California Primary Care Association, and really gearing up for next year's presidential election. And so, but on this topic in particular, and our direct outreach, all the way to our patients' front doors, we've really demonstrated that commitment. And through us and through our community members' voices, we are able to, share the gospel and the word of the resources that are available to them, and engage them in conversations on, the social conditions that are really making them sick. And for us, it doesn't matter. It has never mattered whether they are documented or undocumented, whether they are eligible to vote or not. It really is about creating real access in a culturally aligned way for these communities. And so best practices in terms of models, I think it won't surprise you all that, what works in this space is our approaches that are rooted in community trust and awareness building. So again, through our street vendors program, we engage them to disseminate information, combat this mis and disinformation, and they're spreading the word on Medi-Cal expansion, Medi-Cal redetermination, and the intersection between public charge and eligibility, right? Because we know that fear and that chilling effect is still out there. We've also, they're also conducting outreach at vendors' places of work, and then local schools when they're picking up their children. And so that's an exciting program. We're also found out in our conversations with the street vendors that they have very immigrant heavy social media and community networks. And so they know firsthand the fear that their immigrant communities are facing around enrolling in these programs, and are really helping us to break down these structural barriers. And so 18 of the 35 street vendor ambassadors that we worked with this year themselves have actually accessed Medi-Cal now because of the programs and trainings that we've provided them. Their own experiences, of course, are fueling them to share this information with their families and community members. And broadly, as an organization here at AltaMed, we will educate and provide assistance to nearly 100,000 Medi-Cal patients, 10,000 people who will receive automatic coverage during the pandemic, or who received automatic coverage during the pandemic, and another 27,000 self-pay patients, uninsured patients who received services from us for the past 24 months. So our reach is really broad in this space. Areas of opportunity always continue to exist. I think, the development of strategies that meet community members where they are absolutely critical. Reaching the communities with messages that are relevant to them and their priorities, so that they know that
1 minute left, Berenice.
Folks serving them truly care about their well-being and understand the priorities, their priorities, like from them, and that we have a real connection with them. And also, doing the hard work to form partnerships and training and mobilizing existing community members. So that they themselves can spread this information effectively, inform the public about these coverage expansions, and then identify outreach strategies that leverage the community assets that they shared with us on their socials and their clients that are coming to their businesses as street vendors, and their actual networks. And so I just want to, again, thank everybody for the opportunity of being here. But it really is about being that trusted messenger and delivering the message in that culturally appropriate way in the language, and meeting communities where they are. That is really what has been making the difference here at AltaMed. Thank you.
Well, thank you very much, all of you, for the great points that you bring to the table. And I would like to start this conversation asking Sarah first. Although all of you are welcome to follow up. Did you expect, Sarah, you you made this distinction between the expansions of Medi-Cal among children, young adults, and older adults. And this is going to be the largest one. Do you expect any differences from this expansion compared to the other ones?
I think one thing that might be a greater consideration for this population than the others is these are people who are peak workforce age. Again, not that people over 50 are not working. Many of them are, especially in this community. People have to continue to work even into old age in order to get by. And then again, not that young folks are not working either, but a lot of times many of them are in school. But these are people who, to a greater degree, I would think, are going to have a hard time taking time off of work, and like getting connected to a place where they can, sit down and fill out a Medi-Cal application. And so I think that's one challenge that we want to make sure isn't overlooked. And that's why the organizations and CBOs that have the capacity to go out and meet people where they're at, and help, give them information, and in some cases even do the actual enrollment on site, that's going to be a key success factor when it's possible. And it's not always possible, but that's what we heard from a lot of our partners on the ground with like COVID vaccinations, for example. A lot of the farm worker communities, for example, that some of our partners work with, cannot take time off of work at all, and in some cases are in rural areas where they'd have to travel a long distance. They may not have access to transportation. And so the easiest way to get them vaccinated for many groups was go out to the fields and literally set up, like mobile vaccination stations. So best practices like that, I think, are going to be especially important for this population. And that's just one thing. I'm sure there's others too that I'm, not thinking of.
Anyone else? Anthony, Berenice, Lucia? Okay, so my next question is for Anthony. You mentioned this proposal about opening the exchanges for those who are going to remain ineligible given their income threshold. And as Sarah mentioned, yes, particularly this share of the population is going to be considerably a higher income. So millions of these individuals are not going to be eligible for the Medi-Cal full scope medical eligibility. So how, in addition of this proposal of opening the exchanges to undocumented immigrant adults who don't meet the eligibility requirements, what else do you think could be done? And what are some of the specifics that would need to happen in order for the exchanges to be open to this population?
Yeah, so I mean, I think there is a couple of different issues. I mean, the first and foremost is just the legal one, right? The explicit exclusion that exists now in the federal Affordable Care Act. We had the Health for All campaign, Health Access, CIPC, worked to try to undo this in 2016 and actually got a bill passed and actually had Covered California submit a federal waiver and ask to actually get permission to waive this rule at the federal level. We did that in 2016. Unfortunately, with the new president coming in January 2017, that had to be withdrawn. But we actually are seeing some progress in some states like Colorado and Washington in doing that. I think what but we also don't want to have this ever be subject to the whims of the federal government again. So our approach is actually in the next year is to set up this mirror marketplace so that this is something that we can do at the state level where we don't need federal permission, where we can have a coordinated effort. And if we need to separate some things on the back end to deal with the legalities of the federal law, we will do that, but that people can go to Covered California. Again, 70% of undocumented immigrants are in mixed status families. And so there's a lot of families where maybe one parent is documented and the other is not, and so that they can come in together to Covered California, and Covered California can serve all of them, and again figure out a coverage solution for all of them. In this first year, we're probably not going to get like the same level of affordability assistance that everybody is eligible for in Covered California, but that is ultimately a goal. Ultimately, our goal is that everybody in California gets the same level of assistance, whether it's in Medi-Cal or whether it's in Covered California. And if we have to do that in stages, like we did for Medi-Cal, we will do that. But that is our goal. That is our North Star, that we have a health system that is fully inclusive. That I'll leave it to my other co-panelists to talk about the work of outreach, and which also is important regardless of the income level.
Yes, thank you, Anthony. So Berenice, you talked about community trust. What else can be done in the community to address language issues and immigration fears? I think I found it very interesting that you actually made reference to online mis and disinformation about Medicaid enrollment, because that comes like really regularly in my research. So I wonder how community organizations can get up to speed in trying to address this and make the community aware of their eligibility and trustful of institutions that are offering them this type of coverage.
Yeah, thank you for the question, Arturo. I think, one thing that, we always talk about is the role as a trusted messenger, right? But it takes years and years. AltaMed has been around for 55 years. And so, you got to do the work, and you can't supplement the time, right? And really the reputation that you've built in the community. So that's the easy but hard part, because time has to go by, right? I think the other really important part is having the healthcare workforce that reflects the communities that we're serving. It is amazing to be able to, be in a place and space where we have essentially expanded coverage to all undocumented adults who qualify, right, for the program here in the state of California. but the health workforce that is here to serve them is not at a place that it needs to be. You know, we worked with you all, right, a few years back to really assess the Latino physician shortage here in the state of California, given who is eligible for these programs in the state and who were the remaining undocumented, which are overwhelmingly Latinos. And, you know, that report that we worked with you all said 500 years to parity to the white counterpart. And so we continue to try to find ways, along with supporting here my colleagues at you know, Health Access and CIPC on the coverage expansions at the state level to shore up that health workforce. And, you know, can we look at UC Prime as a pipeline program? You know, can we look at other factors in the Healthy Places Index or Social Vulnerability Index nationally to redirect or prioritize resources in the communities that have higher language needs, for example? What can we do around the nursing workforce? At AltaMed, you know, we have residency programs and we have nurse practitioner pipeline programs, and we're supporting our medical assistants and certified nursing assistants to become LVNs and to become RNs and helping them financially to support that journey, right? And so we're being as innovative as we can. And so it's about, I think, bringing community health centers and large healthcare providers to this space to really serve as training hubs for this workforce, but also pushing the systems that are already here in the state of California to do more to address the pipeline programs that we have. And then looking externally, like right now we're participating in the Mexico pilot program where we're literally bringing doctors from Mexico to serve our patients at federally qualified health centers. Growing programs like that, I think, is of critical importance as well.
Perfect. Thank you, Sarah. Anthony, do you have any insights on how we could address this myths and disinformation to encourage eligible individuals to enroll in Medi-Cal?
Nothing beyond what I already shared before, and I think Berenice's answer was perfect, so nothing to add.
Great. Well, so one of the findings in my research is that sometimes it's easier to enroll individuals who are already have a relationship with a healthcare system, either through the emergency room, they're either members of Medicaid emergency. However, there are millions of people out there who have never had any contact with the healthcare system. They don't know how to navigate it, and now they are newly eligible. And as Sarah mentioned, many of these individuals are working age. They have a high cost of going to the clinic to enroll. So what do you think could be done to engage this population, since from my perspective, it's going to be like the most hard to enroll population? Any of the speakers who wants to start, feel free.
So Arturo, I'll jump in on this one. I mentioned in my remarks that we have to develop strategies that meet community members where they are. So this literally means like going into the communities and observing like where folks are that you want to reach, right? Like, what schools are at? What schools do they attend? What churches, parks? Are there swap meets, laundromats, restaurants, corner stores, whatever it is, right? Then informing them, right, about this and developing that partnership, and then bringing them into the conversation, right? I mentioned to you all our street vendor program. During the whole pandemic and when we were trying to get the word out about vaccines, we actually built out this program because we said, you know, folks are, you know, they're part of the essential health workforce. People are going and eating at these with you know, getting their food with the street vendors. And then at that time, remember, the restaurants were kind of impacted. And so this provided another opportunity. And so as we looked in our communities, we're like, hey, our street vendors are still out there. How can we leverage them to be our messengers? And so we've grown this into a bigger program. And now they're actually out there, like literally almost serving the promotores type of role to reach these communities. And so You know, it's again another easy answer. You got to meet communities where they are, and you got to go where they are. But in order to do that, you have to build that relationship. And so that's what I'll say in terms of how we have approached this issue.
Anyone else? Anthony? Mm-hmm.
Yeah, I mean, I think one thing is that we need to have a health system that puts the burden of enrollment on the system rather than the individual. And that, I think we're trying to do some of that right now. So to the extent that there are undocumented folks who are in restricted scope Medi-Cal because they visited an emergency room in the last couple of years, and so are in the system in that way, we know who they are, we know where they live, we know that they're generally eligible from an income point of view. They just weren't eligible because of their immigration status. Those folks are being automatically enrolled in full scope Medi-Cal starting in January, or if they're part of this 26 to 49 age cohort. And that will enroll hundreds of thousands of people automatically. And we did that in the previous expansions as well. So that is a important thing that California can do, is to make coverage not just accessible, not just affordable, but frankly automatic. And that's the more we can do that, the better. Now that still means that we need to have the outreach to find people who are not in this, who are not in the computer systems, and do the outreach that Berenice and others have talked about. I would say that we also need to make sure that they have connections with, whether through community health care workers or others, so that they use that coverage, that they actually take advantage of engaging with a primary care physician, use if they've already been using a community clinic like AltaMed, that they continue to do so. But now will be a paying patient, and now will feel more empowered to get the care that they need. So there still needs to be that human touch, but we can do things on the policy end to make this system much more seamless, and we need to do that for this population, and frankly for everybody, and that's what we're trying to do.
Great, thank you. There's actually a related and very interesting questions from the audience. Jerry Abraham asks if you see a role for street medicine and community-based mobile programs as a resource strategy for expansion. I think this could be a good strategy for getting to reach these populations. What do you think about it?
I agree. And hi, Dr. Abraham. So I definitely agree with Dr. Abraham. There's a lot of in neighboring county, Orange County, we're working with CalOptima, which is the designated county organized health system, on exploring opportunities for this particular program. A lot of this work started around the homeless population. And is now expanding really to target just high need individuals in the community. So back to that point of meeting communities where they are and literally providing care at the point of service. Right now, some of the models that we're exploring at AltaMed is, providing that care at the point of service, but also the support services. So things like having a health navigator on that team and on that mobile unit to enroll folks, to answer questions about Medi-Cal expansion or Medi-Cal renewal, or other types of social services and programs. And so absolutely agree that this could be a model. Again, to Anthony's point, we need that support from counties, their health systems, LA County, the state, to really direct dollars into these types of programs, because right now they're severely limited.
And at this point, many states, well, not many, some states are expanding Medicaid coverage to undocumented immigrants, like California. Other states like Illinois, New York, Washington, Colorado have been making efforts to expand eligibility for undocumented immigrants. And in the case of Illinois, the recent expansion to adults and older adults was stopped given funding issues. Right now, they're like in a situation where the enrollment was canceled for the year, and they are looking into establishing co-payments for undocumented immigrants who use the program. Do you anticipate something like this in California? Do you think that the funds are not going to be enough to enroll all of them who might have interest in enrolling?
I think that that is an issue that we need to be vigilant about going forward. I mean, everything, these are big wins. These are, we got a lot of wonderful commitments from legislative leaders to make this, to have this as a priority in our budget. But if California has a tough budget year, there's no guarantees. This is not something that's federally required. This is something that the state does on its own. And so there needs to be that advocacy to make sure that this continues to be a priority with our California legislature and governor, and that we also fight for the opportunities for investment, whether it's through revenues or other means. Just in the last year, we passed an MCO tax that was a way to draw down more federal funds that went into improved provider rates to bolster the Medi-Cal program. But I also want to be clear, this is now part of the Medi-Cal program, and this is this is a huge program. This is a program that is over $100 billion that covers 14 million Californians. So the fact that there's hundreds of thousands of folks right now that are covered who are undocumented is actually a relatively small percentage of the overall scope of this program. If we ever do go into it, this should not be where you start cutting, and that's what our advocacy would be. We also want to help our friends in other states so they can take progress, whether it's Illinois, who actually was competing with us to be the first to cover the older population, or a place like Connecticut, which started by covering kids up to 9 years old, and now I think is going up to 12 years old. New York, which has been trying to put that pass a similar measure, but has stalled partially because of those fiscal issues, or states that are going forward, like a Colorado, like a Washington. So we're excited that what we're doing in California has spurred efforts around the country, and we want to continue to inspire that.
Thank you, Anthony. So, Lucia, in the brief that you presented today, you also make references to some examples in Washington and Colorado that could inform the next steps for California. Can you provide us a brief snapshot of that and what California could learn from these experiences?
Yes, thank you. So they did it different. Both states took a different avenue. In the case of Washington, they requested a waiver from the federal government to be able to use those funds, which is what Anthony mentioned that we wouldn't want to do, to not depend on the federal government. And Colorado created something like a mirror exchange, a program called OmniSalud, and they are financing it entirely with state funds. So initially, we suggested to go down the waiver avenue, the waiver route, because it could be more stable. But it looks like we might be generating something in between, like the mirror exchange that might look more like the OmniSalud program in Colorado.
Great, thank you. So I'll move now to some questions from the participants. Dolores Acevedo Garcia is asking, do you see a role for obtaining ITNs in making enrollment automatic through text systems? If not, how else could this happen? Do you have any one of you could answer to this question?
Yeah, so ITIN, individual taxpayer ID numbers, are issued by the IRS, which is a federal agency. At this time, I haven't heard any conversation about trying to have information sharing between the IRS and the state. And I think there'd be a number of reasons to potentially be concerned about trying to do that. I think the proposals that I have heard that seem like maybe a better idea are other state agencies at the state level in California. Employment Development Department, for example, when people apply for unemployment, there's been proposals like that. Obviously, that doesn't apply to undocumented individuals because they don't qualify for unemployment, but these are some of the examples of ways that people have talked about streamlining enrollment for covered California and Medi-Cal in other ways for other populations. And so I think it'd be a really great idea to think through what other state agencies might have information. We know that right now the state is planning to expand our CalFresh program, food assistance for undocumented individuals ages 55 and older, starting in October of 2025. I think there are plenty of opportunities to think through things like that. If someone's already in Medi-Cal, could we think through, trying to send them information to let them know that they're, based on their income, we know they're eligible for CalFresh as well, or vice versa. So that would be a place to look, I think, as some of these state agencies that do have information on people, have their income information, could, share it with another state agency like the Department of Healthcare Services and make those determinations about who's eligible and either automatically enroll them or at least notify them, take the extra step to notify them that with some additional steps they could get enrolled.
Great, thank you, Sarah. And one last question before we wrap up. Do you see any role of counties supporting the efforts of the state government to expand and outreach to this population?
Yeah, I would say counties right now are one of the major drivers of enrollment into health programs. They are the ones who do Medi-Cal eligibility, and so that's an incredibly important source of that. They also, one thing that we've been heartened is that there have been efforts like counties to provide indigent care. That is a responsibility of counties. And there have been programs, whether it's having public hospital systems like LA or coverage like systems like My Health LA. And actually, My Health LA will be winding down at the end of the year because all of the folks that have been in My Health LA, which peaked at over 180,000, will now actually be eligible for Medi-Cal. And so those folks will be enrolled in restricted scope Medi-Cal, and as I mentioned, then automatically shifted into comprehensive Medi-Cal in January. So that's an important role for counties. But I also think there's a role for counties, and there are some counties that are exploring, especially if they provided indigent care only up to 100 or 138% of the poverty level, which is not very much to begin with. That they look at providing indigent care above that, because as we said, there is a gap for those over 138%. People making $20,000, $30,000, $40,000 a year. Even for a family of four, 138% of poverty is $40,000 a year. If you're just making above that, you're still struggling with costs in general, including healthcare costs. Having some indigent care options by the county is, I think, really important until we achieve the goal of doing health for all at the covered California level as well, including affordability assistance. So there is a real role for counties to continue to be a provider and an assister of last resort with regard to healthcare.
Well, thank you very much. Great participations today. I learned a lot. I hope that the audience also was able to learn about this important topic. And before finalizing this webinar, I would like to thank the California Endowment for supporting this webinar, and to all of you for your questions and your attention. Thank you very much, and have a great day.